Everyone for joining us in our international rounds. And it's my great pleasure to introduce Professor Dori, who is a pediatric interventional cardiologist at CHOP, where he's the director of the Jill and March Fishman Center for Lymphatic Disorders. And is going to talk today about a very interesting topic, which is lymphatic disorders in patients with heart disease. I always feel that the lymphatics are the forgotten vessels, and I'm sure today we're going to learn a lot about of them. So, Professor Dori, thank you very much for joining us, and the floor is yours.
All right, thank you. Can you hear me well?
We can hear you perfectly.
Good? Okay, good. All right, so first of all, thank you guys for inviting me to give this talk. It's really a pleasure to be here. Hopefully you'll learn something today about this, and we'll, as was introduced, we'll talk today a little bit about what I deal with most of the time, which is lymphatic dysfunction in our patients. So as was said, Rafa was just saying that the lymphatic system was known as the forgotten circulation. So a little bit of background in history, back in the 70s, people studied a lot of lymphatics. That was in the good days where you could do all kinds of interesting things to patients before IRBs and all those things occurred. But because there was really no easy way to look at it, and there was no easy way to image the lymph system and nothing really to do about it. There were no real interventional techniques. Then for 40 years, it kind of just disappeared from our radar. Lymphatic system has several functions. One important function is the defense function. So it plays a key role in immune regulation, and we're not going to talk about that at all today. It plays a very important role in transport. So fatty acids are absorbed actively through the lymphatic duct. So when you eat, one of those American McDonald's, all the long chain fatty acids, because fat and water don't mix, they need to be packed in particles. They're called chylomicrons. And those are released into the thoracic duct, and that's what makes the fluid white. We're going to be spending most of the time talking today about the circulatory role of the lymph system, although the other roles are extremely important as well. Lymphatic system plays a role in probably many disease processes, and many of them that we haven't even started to explore. We all know the role in cancer, but the role in heart failure is extremely important, especially in congestive heart failure, which is really the biggest problem in the world right now. And that occurs in the adults that you guys are going to be treating. So you see it because you're dealing with the end stage of not just the single ventricle palliation pathway, which a lot of them are going to get there, but also some of the other ones. And this is a kid who's now, he doesn't look like it, but he's 19 and has severe ascites and he's end stage heart failure. He does have a single ventricle heart disease, and that is a lymphatic problem. So when we talk about our lymph system, I usually use this slide to depict the regular anatomy and flow. Flow in general is from the peripherally towards the center. Okay? Two main streams for lymphatic drainage is the liver and the mesentery, both contributing about 40% of each contributing 40% of the thoracic duct flow. In normal people, flow in the thoracic duct is about 2 to 3 liters a day. In a patient with a single ventricle, it can be 10, 15 liters. And in severe heart failure, it can be up to 30 liters, maybe more, we don't know. Thoracic duct courses right on top of the vertebral bodies between the aorta and the IVC. And in most people, drains to the innominate vein on the left side or the subclavian vein, IJ junction. There are anatomical variants to this. There are patients or people where it drains to the right, and then there are people that have bilateral ducts. Starling, about 100 years ago, derived this equation for tissue fluid formation that just tells us that tissue fluid is formed by the difference between hydrostatic and oncotic pressures. And to a first order approximation, that is a reasonable approximation for how tissue fluid is formed that ultimately will make up the lymphatic flow. Most of it goes to the veins, but about 20% of that fluid is going to go into the lymphatic duct. Missing from this equation is a term that talks about the lymphatic capillaries, because if you have perfectly fine hydrostatic and oncotic pressures and you have completely dysfunctional lymph system, you're going to create a bunch of tissue fluid. And that's not in the terms here. Lymphatic capillaries are present everywhere there are blood capillaries, as shown over here in the picture. They are different in their anatomy and function because they're function is to just absorb fluid. So they're much more porous. They're connected with anchoring filaments, microtubules to the extracellular matrix. So then when the tissue swells, the lymphatic capillaries become more porous and more fluid can go through there by capillary flow. Now, just like on the cardiovascular side, if you want fluid to flow in a unidirectional way, which you have to have in the lymphatic ducts for this to be functional, then just like on the cardiovascular side, you have to have valves. And there are valves inside the lymphatic ducts every few millimeters. And you need something that is going to push the fluid. On the cardiovascular side, we have the heart. On the lymphatic side, we don't have a heart, but lymphatic capillaries will, the lymphangions will pulsate, like you can see over here, and that will move the fluid. In addition to that, we do know that there's a very important respiratory pump. Okay? So when you take a breath in, negative pressure pulls fluid into the chest, into the thoracic duct, and when you exhale, positive pressure pushes fluid into the vein. In addition to that, there's muscle and aortic pumps. So, and we've seen it actually in patients. We've seen the aorta. Sometimes when it sits right next to the duct, it can push on the duct and cause fluid to be ejected out. And this is an example of a patient with a very dilated thoracic duct with valves every few millimeters. There are many factors that affect lymph flow. Everything, so if you're an intensivist as part of this, everything that you're going to do to your patients, but even not just in the intensive care units, all the drugs that you're going to give your patients are going to affect the cardiovascular side, are going to affect the lymphatic side. And there are many other things. We won't go through all of them, but this is the response. This is research that was done by a very close friend of mine, Vibeke from Denmark, and a collaborator. And just showing that how lymphatic ducts respond to norepinephrine in a dose-dependent manner, and they start to pulsate much quicker, and the amplitude of the pulsations of the duct increases. We've now done and published several papers about the pressures inside the thoracic duct, which was previously unknown in people. And we now know that inside the thoracic duct, there's spontaneous contractions of the duct every 10 to 15 seconds. And those are important for pushing the fluid. We also know that the duct can generate a significant amount of pressure in response to an occlusion. And you can see that over here. This is acute occlusion of the thoracic duct outlet. And you can see that duct pressure increases significantly from about 10 to 40. And we know that the duct can generate up to about 60, 70 millimeters of mercury inside there. And so this is extremely important. If you are occluding the duct, this is what you're going to acutely get inside your lymphatic channels. And that has significant implication for tissue fluid formation and things like that. For babies, not so much for the adults, but also for the adults. And there are people that have used this to try to help, for example, single ventricles who have problems with edema. There is some literature out there about using negative pressure, for example. There's a negative pressure shell that you can use to help them, to help relieve some of the respiratory problems they're having, but help alleviate the positive pressure that occurs in the chest and hopefully pull more fluid into the thoracic duct. And we know that if you increase ventilatory support in our patients, or in any patient, but especially in babies, that increases intrathoracic pressure, increases CVP, causes lymph dysfunction, and that can cause, in some cases, the pressure in the chest can be high enough and the CVP high enough that even in adults, you can completely shut down central lymphatic flow. Babies are extremely susceptible to this. And if you put ventilatory settings high enough, you will shut down their flow. And just to show you how that works, here's a child with a severe lung disease, but you can see the duct is extremely dilated. All the flow is going into the baby's head instead of going into the thoracic duct over here. And when we turn off the ventilator and lower the pressure, you can see that the thoracic duct starts draining. And that has enormous implications for the babies that we treat that have these problems, but also most likely has implications to adults and the patients that we treat when they get intubated or if they're having respiratory problems. In the heart disease world, this is the crux. Ultimately, even the elevated PEEP, the end common pathway to this is elevated CVP, elevated central venous pressure. And what elevated central venous pressure does is two bad things. So if you are a child born with heart disease, let's say a single ventricle heart disease, and you have normal venous pressure, then you have normal lymph production in the liver and normal lymph drainage in the innominate vein. But Once you convert a child like this to a gland, your pressure in the IVC is still relatively normal, not completely normal. So you probably have a little bit more production, but the pressure in the gland is your afterload. So now you've inhibited drainage of the lymph system. And we start to see already the consequences of that and some congestion in the system. But once you convert a patient to a Fontan, or any patient that has elevated CVP everywhere, so this can be tetralogy of Fallot, some of the truncuses that we've dealt with, and many other kind of heart disease patients. And as soon as you do that, you increase lymphatic production in the liver significantly, and at the same time, you're impeding drainage. And it's a combination of these two things that is quite devastating for our patients. In addition to that, there is a problem in some of our patients, which I mean, I can't say for sure that it's a genetic problem, but they have a system that is susceptible to the lymphatic abnormalities that we're dealing with. And it is really the combination of these two things, where you have a system that is the piping is susceptible to bad physiology. And you have the bad physiology with this double hit, and this combination ultimately will lead to lymphatic failure in the patients and the symptoms that you will ultimately see. Now, as I said before, imaging was the thing that was missing, and that's why it was known as the forgotten circulation. So when we started working on this more than a decade ago, this was the thing that we concentrated on. T2 imaging has been available for a long time, articles from before we started on this. And this is just looking at water, and it's useful for certain things, and I'll show you in a second. But when you're dealing with a circulatory system, you have to be able to characterize at least three things. In the engineering world, we call it degrees of freedom analysis. But three things you need to characterize in order to be able to define your system, and it's just like on the cardiac side. So it's your anatomy, your flow, and your pressures, your lymphodynamics. T2 gives you anatomy, not perfectly because you can't distinguish lymphatics from edema, but it doesn't give you flow. MR lymphangiography gives you flow, and this was really what changed everything about our understanding of these diseases that we treat, was developing of these techniques. And this was the first one that we kind of worked on, which was intranodal lymphangiography that we published a long time ago about. And that is just access of lymph nodes in the groin, very simple to do. And injecting MRI contrast is using the MRI technique in order to show us the dynamics of how the flow is occurring. So this is normal intranodal lymphangiography. You can see dilated lumbar lymphatic, thoracic duct going to the left. What this is missing is the two most important streams for lymph drainage, which is liver and mesentery. But I'm happy to say that we've now overcome that. So we routinely now do intrahepatic dynamic contrast lymphangiography. And we initially published about that in 2019, and that's simple. It's also relatively simple to do. You just access the liver lymphatic channels. Injection in the liver shows retroperitoneal lymphatic channels going up, connecting to the thoracic duct going to the left. And then the mesentery, which was the last part of the system that really historically has never been imaged, but by looking at the images that came from the intrahepatic imaging, we kind of understood how the mesentery flows, and then we were able to develop the techniques to do this routinely. And so we do this now routinely in many of our patients with very high success rate. In about 95% of the cases, we can get all 3 points of access and image them. And this is what intramesenteric imaging looks like. So we have a needle in the mesentery. This is the mesentery lighting up, connecting to the sternochyli, and then thoracic duct going to the left. There are some other techniques that we've published about, and one of them is ultrasound contrast. I'm not going to show slides because we don't have time, but that's a very good technique to determine thoracic duct outlet patency, for example. You can read about. Now, the other part of this that I talked about was the interventional part. So this is an intervention technique that was developed by Konstantin Kopp from the University of Pennsylvania. He was an interventional radiologist. This is thoracic duct access. And this was developed more, he unfortunately passed away a few years ago, but this is using a needle, getting into the sternochyli, which has oil in it, and putting a wire in there, and then you just put a microcatheter and you can do all the interventions that you can do. But there are many other techniques that we use now to access the ducts, and all kinds of interventions that we do that don't necessarily require access. Interventions, there are all kinds of interventions that we do. This is thoracic duct embolization. So this is putting a coil and glue into your thoracic duct, and the glue is simple. It's histocryl or glue brand or Trufel. It's basically super glue and butyl cyanoacrylate. Same stuff you buy in the supermarket for $1, costs a little bit more when you're putting it in people. But this technique of thoracic duct embolization, just shutting down the duct, in cardiac patients should almost never done. So the only reason I'm showing it to you is because in certain cases we do it, but almost never anymore. It's very, very rare for us to do this. It's the wrong thing to do in most cases. Much better to do selective procedures. So find where the problem is and just target that. For example, in a patient over here with the channel coming off the thoracic duct causing the chylothorax and flaccid bronchitis. And you can see after the procedure, we shut this down and you can see the thoracic duct is draining perfectly fine. And this is the optimal solution, and symptoms in this patient completely resolved, and the patient is doing perfectly fine with this. There are many procedures that we've done inside lymphatic ducts. Almost everything that we've done on the cardiac side, we've done on the lymphatic side, except for implantation of valves. There are no valves currently available for this kind of stuff, but everything else. And there are certain procedures that are meant to shut down things, like putting coils, gluing. But there are procedures that we now do also that are meant to decompress things. And those are just as important for our patient population. And it's really the combination of these two things that lead to the optimal result in many of our patients. Now, if you look at our single ventricle population, we've done a lot to optimize their cardiac side and their medications and all that kind of stuff. So survival for these patients has improved dramatically, but these patients are surviving with problems. And it's not just the single ventricle population, it's all of our congenital heart disease populations. That's what you guys are doing. You guys are overwhelmed now with work because of this population that only you guys take care of. Nobody else wants to take care of them, but a lot of them have a lot of problems, and especially the single ventricle population, a huge amount of problems that are dependent on end organs and all this kind of stuff. Now, when the book from Atlanta term, because in the adult world, and you guys are very familiar with that, there's all different ways of naming what heart failure looks like, right? The FF, FPEF. In the lymphatic or the single ventricle world or congenital heart disease world, there was no real good way to do that. There's not like HFrEF and HFpEF is not really tell you what's going on with them. But she termed these two things, which is the FFNH or whatever, which is the normal or low SVR cardiac output. So this is basically patients who have everything in the cardiac side seems to be normal, but they have a significant amount of ascites. So the heart is still systolically functioning okay. Everything looks okay over there. Nothing has significantly changed. And then there are patients with this L, the lymphatic failure problem. Okay, but I will dare to say that actually the FFNH patients are also a lot of them are going to be a lymphatic problem, because that is the group that is the end organ damage group. When we talk about lymph failure in our population, there are the patients with clear lymph failure, which is PLE, flaccid bronchitis, and chylothorax. And then you have the ones who have ascites and edema, and I will say, and we just published an animal study that pretty much proves this, but talks about ascites and edema in the context of lymphatic problem also. This is not just a cardiac problem. And then there's the end organ damage problem. And ultimately, we need the tools that allow us to treat these things, because this is what our patients are going to experience. Now, which of our patient population is at risk for this stuff? Well, we know all the single ventricles are not just at risk. Most of them are going to experience certain forms of this. Noonan's patients, trisomy patients clearly are at risk for this. TGA is a huge problem, have a huge lymphatic problem. Some of them will present as neonates, but others present a little bit later. Not all of them have this lymphatic problem, but when they do, it can be a big problem. Patients after heart transplant can have lymphatic problems. But we've seen lymphatic problems with almost everybody else. Right? So you can have it with all kinds of other diseases, but really it's the top group that is what we see the most. Now, in addition, as I said before, there's the lymphatic failure part, but there's the end organ part. And this is part that is not completely 100% understood, but if you've treated people with long-standing severe lymphedema, you know that their characteristic of their tissue is that it's edematous, but it's also very stiff. It becomes fibrotic, fatty changes, and all those things. And we know from that world that edema, tissue edema, leads to lymphangiogenesis, fibrosis, inflammation, and all those things we see in the organs in our patients, the livers, kidneys, and everything else. And it's obvious that lymphatic system, which is responsible for some of this edema, is going to play a role ultimately in this end organ dysfunction. But what role exactly is that playing? That's a great question, and something that, you know, people are starting to look at now, and we will discover together all that stuff in the future. So we'll start talking a little bit about the lymphatic dysfunction in our patient population, and specifically as dealing with the stuff that is in the chest. And in the chest, you can have pleural effusions, pericardial effusions, and plaster bronchitis. So you can leak into any one of the open kind of membranes, because those are places which have lower pressure, and it's a good place for lymphatic system to decompress into. And really, the cause of all these three things in our patient populations is always kind of the same. And it's this thing, it's this abnormal perfusion. And this occurs in tetralogy of Fallot. We've treated tetralogy of Fallot patients with cholelithorax and plaster bronchitis, truncuses, single ventricles, all kinds of diseases. When they present, it's usually this, unlike what we saw before, just the thoracic duct going up, you see this abnormal flooding of the lung with lymph. We call it this pulmonary lymphatic perfusion syndrome or abnormality. And it makes sense that if you have this, then, you know, leaking into your pleural surface or into the airway, which sits over here, you know, it's not unimaginable that that can happen. We've classified this, and the only reason to classify this is because it tells us something about the intervention that we can do. Because if you do like type 1, 2, 3, they have a thoracic duct, it is connected to the vein. And if you have that, then really you should be shooting for a selective procedure. If you are type 4 and have a duct but is not connected, you can reconnect it. And that's the target procedure that you should do. If everything is completely disorganized, you're a trisomy or a Noonan, then sometimes there's nothing really to do. Although, even if you have a proximal remnant duct, we can sometimes use that to reconnect. But sometimes you just have to embolize things. And then if you're imaging, if you have a problem and you don't see any abnormality in the chest, then this is what is happening. And we think that this occurs in probably like 20 to 25% of our patients, where the thoracic duct is not playing the major role. It's the connections from the liver directly up, called hepatopulmonary connections, that are contributing, and I'll show you what that looks like. For thoracic lymphatic abnormalities, we can use T2 imaging to screen, and we published about this. And people have now looked at T2 imaging, not just to screen, but T2 imaging further along in the process. And it looks like T2 imaging throughout the entire process, from before birth, actually, because we can see T2 abnormalities in utero. So from in utero all the way to the end of their life, probably T2 will correlate probably better than anything else with what their clinical symptoms look like and how well they are going to do. And we know if they have high-grade T2 abnormalities. So there's type 3, which is T2, which is edema, and I'll show you what that looks like in the mediastinum, versus edema extending all the way out into the peribronchial area and into the parenchyma, that patients with these kind of T2 brightness in the chest will have problems, okay? And this is what it looks like. So this is the mediastinum with T2 brightness, and this is just everything is T2 bright, the interstitium, and the patient has effusion, and also T2 bright in the belly. This is a multi-compartment problem. This is a huge problem. This is a type 4 patient. And we know that this correlates perfectly. So if you look at Glenn, and they have that, and I'm a cath doctor, and I know that cath numbers, for example, don't correlate very well with outcomes, with who's going to do well as a Fontan, but T2 does. So if you're a type 1, 2 patient, as long as everything is fine and your valves are functioning and your heart's pumping, you're going to do perfectly fine. You're going to get through the Fontan unless the surgeon did something crazy during the surgery. But if the surgery went well, you're going to be fine. You're going to get out of the hospital within about 6 days, and you're going to go home and you're going to have no problem. If you're a type 3 patient, you're going to have some effusions and probably plaster bronchitis later, but you should be, with careful management, you should be okay. If you're a type 4 patient, you are in trouble. You should not actually go into a single ventricle palliation pathway without understanding that you have a type 4 and without some understanding of what you're going to do. In certain patients, for example, a Noonan's patient with type 4 abnormality, there's no way they're going to go through a single ventricle palliation pathway. Should never be done for them. And trisomy 21, the same thing. So it just needs to be aborted, or using some other method to alter the lymph system, which we potentially have now, that will allow you to go through that pathway, but that's the future will determine that. So again, when should we do T2 screening? Well, we do all of our pre-Glens and pre-Fontans, but we know that we can screen them in neonatal and newborn, and we know potentially that we can screen PLE. And what we do now, post-Fontan surveillance, so any patient in our institution that is getting a cardiac MRI, T2 imaging is part of the sequences. It's just routine sequence now. They're all getting it. So they're all getting screened throughout life, and we're following it. And actually, together with Vivica, we're writing a paper now about what happens to T2 imaging as you go along this process. How does it change? How does it get worse in some of the patients? And how does that correlate with things? So that's going to be a very interesting paper that will come out. This, as I said, PLPS is what causes the problems in most of our patients. We used to think historically that it was a surgical problem. Surgeon went in there, cut some duct. I like to blame surgeons for everything that happens wrong, but in this case, we can't. It is really this. So this is a Glen with chylothorax, Fontan chylothorax, Fontan plastic bronchitis. Again, as I said, it's the same problem. That is very different than a traumatic leak. This is a kid with a ring repair that had a traumatic leak. And you can see, usually the trauma to the duct is not the thoracic duct, but accessory channel connected to the pericardium. Surgeons can't see that, so they just do the surgery and they can cause a leak. But you can see it looks very different. There's not all this perfusion. There's just leak into the compartment. Right, and the good thing about this is that this is very treatable. This is an adult he was 17 at the time, so almost an adult, but he was a Fontan who had a heart transplant. You can see a very dilated thoracic duct going up, large channel connected to the pericardium that was severed during the surgery. You can see the leak over here. You can see the thoracic duct is going up and draining right over here. No problem. This kid is leaking 8 liters a day. This duct is enormous and carrying probably 15 liters a day. So you don't want to shut that down. That doesn't make any sense and will cause huge problems. So we selectively shut it down, and within a week, everything resolved and the patient's doing perfectly fine. So that's the way to treat that. Plastic bronchitis is simply leaking into the airway, and we've determined that by going into the duct in a patient with plastic bronchitis and injecting blue dye in there, and you can see the peribronchial lymphatics lighting up nicely, and in some cases you'll see blue dye leaking in, and that's what causes casting, because lymphatic fluid carries proteinaceous material. When that touches air, it denatures, activates the thrombin pathway, things clump, just like when you cook egg white, and that will fill the airway, and when that happens, they will choke and they have to get it out, or they will die from that. This was the first kid that we treated. The nice thing about plastic bronchitis is we really have very good treatment for this. First kid that was treated a long time ago. You can see a single channel that we went in there, selectively shut down. This was in 2012, so we're 11 years out of the procedure, and the kid is perfectly fine. Good Fontan, no plastic bronchitis symptoms whatsoever. So very treatable disease in most cases. And this is the outcome. So they usually come to us casting on a regular basis. And by the time we're done treating them, almost all of them are done casting. There were a few patients, so about 20% of the patients, as I said before, hepatopulmonary is about 20% of them that had residual symptoms, and almost all of these we can now treat because we know that it's hepatopulmonary. So this 80% is much higher. We probably somewhere between 90 and 95% of the cases we can get to almost complete resolution of symptoms. Some of them will get much improvement, but maybe finding the networks that are causing the problem is more difficult. As far as respiratory support, a lot of them before require respiratory support, and after procedure, again, almost all of them are on room air and doing perfectly fine. And the most important thing is that their survival curve used to look horrendous. That is the historic survival curve that was published by Kirk and the Boston people, with a 50% mortality for this disease, horrible outcome. Their survival curve for a patient with plastic bronchitis probably is not going to be exactly what a regular Fontan survival curve, because if they have plastic bronchitis, most likely they have a lymphatic susceptibility, and maybe they'll show up later with additional stuff, but their survival curve should be much closer to what a normal Fontan survival curve should look like than what it was looking like before, and that's shown over here. And when we looked at our cohort of plastic bronchitis patients, and there's an article that should be, I mean, it's in revisions now in JHA, so it will come out with some of our outcomes. We saw that together with plastic bronchitis, about 20% of our patients will have a concurrent diagnosis of PLE. So PLE and plastic bronchitis can occur together, this multi-compartment issue. So you have to understand that all these different things are linked to each other. They don't occur completely independently. Okay? As I said, there's a number of them that have these hepatopulmonary things, and hepatopulmonary connections can cause anything that occurs in the chest can be caused by the liver without having anything to do with the thoracic duct at all. And to show you that, here's a patient with chylothorax plastic bronchitis. When we image, we see a completely normal thoracic duct. So there's no pulmonary perfusion over here, so you don't touch the duct like this, because if you do, this will make things much worse for this patient. We know where to look for these hepatopulmonary connections. We know where to find them. We know how to intervene on them. And so we did it in this patient. Here it is, and this is just a channel connecting from a needle in the liver inside the channel, going directly to the left-sided pulmonary, peribronchial lymphatic. We shut it down with glue, and all the symptoms in this patient completely resolved. So if we're going to go down to the liver, then we should talk a little bit about stuff going on in the belly. And the things that we kind of think about in our patient population, there are several other things, but we pretty much think about the PLE. And as ACHD providers, you're definitely going to deal with these things, PLE, absolutely, and ascites and pleural effusions. But these are the main things that you are concerned with. We're not going to concentrate too much about ascites today because we don't have time, and there's a whole bunch of new data that we have about how it works and all that kind of stuff, but that there's definitely a lymphatic role in this whole thing. And PLE, absolutely. Chris, my partner, wrote this wonderful paper in European Radiology talking about the different connections that come from the liver component and how these different connections play a role in different disease processes. So like we talked about, the hepatopulmonary play a role in chylothorax and plastic bronchitis and in effusions, okay? And the hepatoduodenal connection, so, and I'll show you that in the PLE, that we know correlates 100% with our PLE patients. And there are several other things here. The question is about screening of patients with PLE, and we have data now to show, and we published about this, that we could potentially screen for PLE also before it is occurring. And to do that, you need to do intrahepatic dynamic imaging. And what we see is that in patients, you can have this kind of signature. So this is your duodenum, and you can see that the duodenum is not stained by MR contrast. And here you can see that there is staining of the duodenal wall. Okay, perfusion of the duodenal wall. And we know that that correlates with symptoms, because if you look at the cohort that we looked at, all patients with PLE will have, if they have a very active PLE, they will have leak into the duodenal lumen when you inject the liver. If they are controlled and you put them on steroids and the albumin normalized and all that kind of stuff, then they will have enhancement of the duodenal wall, but in some cases, not a significant leak into that. If you don't have PLE, so your plastic bronchitis, chylothorax, and we image you, most patients don't have duodenal involvement. That's why 80% of them will not develop PLE. But a few patients, we don't know exactly what the number is, but let's say 10 to 20% of them will have staining of the wall. So they will have concurrent PLE, and that is consistent with the numbers that we showed before. So at least in part of their disease cycle, we know we can use intrahepatic imaging to screen for those who are susceptible. And we've now imaged multiple patients. So all patients with heart disease get intrahepatic and intranodal imaging at least. And there are multiple patients now that we have diagnosed with PLE before they had clinical PLE or before their providers even knew that they had PLE. And some of them, we just told them, okay, send out an alpha-1, and it was positive. Okay? So we think that this is a reasonable way. Now, this is PLE. So this is, as I said, you inject the liver. That is the imaging modality of choice for this. And you can see that quick leak into the duodenal lumen with reflux into the stomach. And later on, we diagnosed this patient with gastroesophageal reflux, because this is the stuff going into the esophagus and coming out. Like, there's enormous amounts of leak into the lumen. And what we know happens, and you can see it from the inside, is that over time, lymphatics will erode the walls of the duodenum and cause holes in there. And you can see streams coming out of the duodenum into the lumen of the gut. And these are the streams that are shown in black arrows over here. And we know that this is lymphatic streams because if you inject blue dye into the liver, Shortly after you do the injection, you can see the blue dye just flushing out right into the duodenal lumen. And this is just lymphatic streams carrying lymphatic fluid from the liver. This is why they're losing albumin. This is why they have diarrhea. The diarrhea is this. In addition to that, you can see that the wall of the duodenum is very edematous, very boggy. So it's not going to absorb things the way it's supposed to absorb. So that's why they have all these symptoms. We have developed now a certain pathway to treat these patients, and it is complicated because the area of problem is sitting right over here where this arrow is, and we call it the eye of the storm. And it is because all the different organs of the body, this is kind of where they come together. So you have the mesenteric lymphatic connecting to cisterna chyli here. You have the stuff coming out of the liver, going around the gallbladder, coming over here. You have the pancreatic lymphatic system and the duodenal lymphatic system, which is connected also to the mesentery, and all coming to the eye of the storm over here. And this is where the problem is. This is where we see the leaks. It's usually in the second portion of the duodenum. So intervening over there is complicated. And when we started doing interventions, we were just intervening from the liver and just shutting down the liver things. And what we saw is that we get an acute rise in albumin, but then after a few months, it goes back down to baseline, to the low albumin. And the problem with that is that you're treating the upstream stuff, but really the problem is occurring way downstream over there. So we stopped doing that because it just didn't work. And we started really doing interventions that are around the duodenum, in addition to shutting down some of the big stuff that is coming out of the liver. And what we know now is that normal occurrences, you have drainage from the liver coming to cisterna chyli and from the mesentery going to cisterna chyli, but liver can cause the PLE by draining. The normal pathway is liver out, following the common bile duct and connecting to the second portion of the duodenum and ultimately leaking. But there are also connections that can occur through a pathway that comes out of the liver and goes to the first portion. And there can be connections from the liver to the third and fourth portion. And there can also be connections from the mesentery to the third and fourth portion. And it can also link into the second portion. So all these things ultimately will cause PLE, and that's why this system can bypass some of the stuff that we're doing, because there's multiple networks that this thing can go through. So the goal of what we do now in therapy is to try to shut down really the networks that are causing the problem. And if you get a good embolization, including first portion, second, third portion, then you can cause a alteration in their albumin level for a prolonged period of time. This is what it looks like. That's a needle in the periduodenal network. You can see that when we inject, there are multiple holes over here where the glue is leaking into. And we've shut down the networks that are connected over here. And after the procedure, this is what it looks like. And you can see that there's also injection into the first portion over here and second and part of the beginning of the third portion. And you can see, so this is a paper that should be coming out. It's just a letter that will coming out in JACC, but we've collected our larger cohort now. And you can see that these are patients who have had that kind of procedure, 6 of them. This was 6 out of 10, and that have had a completely normal albumin for years, up to 3 years. I think we're at 1,400 days, so that's even more than that, without medication and without needing to do anything else. So, and that's a single procedure. You don't have to do multiple procedures. Single procedure in all cases will improve things and get things to work. But there's a lot more to this than we can talk in the short period of time that we have. So, so this data we are working on getting out, and we'll get it out soon. Multi-compartment failure is when you have everything, like things going wrong in more than one place. So your adults with lymph failure, a lot of them are going to present to you with this kind of a finding. So they'll come in with ascites, pleural effusions. It could be chylous, but it could be not chylous. And they might have also PLE, they might not. You might have something else. Multi-compartment just needs more than one compartment, and I usually call the chest one compartment. The ascites is another compartment, that's the peritoneum. The duodenum or the intestine is another compartment, so that's the PLE. And then the skin, if they have skin edema, I consider that an additional compartment. So if you have 2 of those 4, then you have a multi-compartment problem, and you have to treat them as such. And they are in a different category completely. Then if you just come with just PLE or just plaster bronchitis, then we target the therapy for that. If you come with a multi-compartment problem, then we need to think about them and treat them a little bit differently. So if you have that and you have a thoracic duct that is not connected, then as I said, we can reconnect that. So this is an example. This is a lymphovenous anastomosis. And in certain cases, this can work very well and can alleviate symptoms, multi-compartment symptoms completely. Other things to think about in patients with multi-compartment problem is thoracic duct obstruction. And we just published this, not like this year, talking about the different things that cause thoracic duct obstruction with pressure gradients across the thoracic duct. That can absolutely occur. And there's multiple etiologies, but one etiology that we've seen in our patients is the aorta compressing the thoracic duct that has this kind of acute turn going around it. And there we've seen patients with thoracic duct outlet obstruction and all kinds of things that are causing pressure gradients inside a thoracic duct. This is an example of that. This is a kid with severe multi-compartment problem, PLE and ascites, because of a lymphatic mass, a lymphatic malformation that caused a big mass in the chest that you can see over here. And you can see what this mass was doing is was pressing on the thoracic duct, okay? And that caused a huge pressure gradient, okay? And you can see that when we did the measurements of the pressure gradient in there was a 15-millimeter pressure gradient across the thoracic duct. So the thoracic duct can do this. We know from even acute occlusion, right? And that is an enormous pressure gradient. So your interstitial pressure below the obstruction is 20 instead of 5. And we didn't touch the thoracic duct in this patient. We didn't do any intervention other than draining the mass. And you can see what happens to the thoracic duct. It straightens out and the pressure gradient goes down to 2. And without doing anything else, no other intervention, all multi-compartment symptom in this patient completely resolved. Right? So another thing to think about in those patients, decompression in these patients is an essential part of their pathway. And we do this in all of them. And this is the Heraska procedure. So this is the surgical Heraska procedure where you take the thoracic duct and you take the innominate vein and just connect it to the atrial appendage. And what this does is it takes the thoracic duct pressure and lowers it by 4 to 5 millimeters of mercury, depending on transpulmonary gradient. And in some cases, this can definitely improve symptoms. But I can tell you right now, just like everything else, we initially think that, this is the magic solution to everything. It's not. There are patients where this is not going to work in. There are patients that will work for a while, but then symptoms will return. But in some patients for at least years, and that's our goal over here, it can make their symptoms much, 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 much better. Now we can do this procedure percutaneously, and we now do it here routinely, just almost all percutaneously, because it doesn't require another surgery when they're adults. And for all practical, almost all anatomies, we can do that. And we published about that in 2 papers now. And that, again, as I said, can work. For the decompression procedure, which a lot of your adults that are going to, again, present with lymphatic problems are going to need this, because the pathway for a PLE that's presenting with a multi-compartment is going to be PLE procedure, shut down the leaks, because if you don't, then decompression is not going to work. And then within a week, after you can start them on anticoagulation, they are going to decompression. So we do those procedures. We consider that a single treatment pathway. They're going to get both, because if you just do one, we know it's probably not going to work very well. And actually, if they're presenting with PLE and ascites together, if you shut down the PLE, you will most likely make your ascites worse. So you can't just do that. You have to have a pathway for them to get out of there. As I said, when we published about this recent paper that came out with 10 patients with multi-compartment failure with suitable cardiac anatomy, and again, as I said, most of them have a suitable anatomy. We do a specific MRI, so it's a cardiac MRI to look at the anatomy. So we need to plan. You need to plan these procedures if you're doing them percutaneously. And in addition to that, you look at their lymphatic system. You have to make sure that their thoracic duct is patent. If it's not, then there's no point to do this. And so, as I said, there's ways to do that. And then we go for a lymphatic procedure, cardiac catheterization. You have to do that because we know now that there are certain pressures that above a certain diastolic pressure or atrial pressure, this procedure is not going to function very well. That will come out in the data. And this is what it looks like. So we have a catheter in the aorta. So you need to know where the aorta lies and where the coronaries are. And we have a catheter coming down from the IJ, and you can see here. So our goal here, okay, is, and you can see that there's a catheter across the fenestration into the atrial appendage, which is sitting over here. And the goal here is to bridge here to here with a stent. And that's what is done. And you can see over here, this is part of the procedure. So we put a snare in the atrial appendage, and then we just go straight down. We go out, and based on the 3D imaging and the printing and all those things, we know what to avoid on the pathway. We know what to look for. We know where the airway is. We know everything else. And then you just get your wire across, snare it, put your stent in there, and now you've completed your HRSA pathway. And within a day or 2 days of doing this procedure, a patient can get out of the hospital. It's not a surgical procedure in a fontan who has already had 3 times at least of exploration of the chest. It's just a cath procedure, and it works just as good. And by the end of the procedure, they will have no pressure gradients in most of them. Some of them will develop peristental leaks that might require another cath procedure, but overall works really well. And in the patients that we did, again, as I said, they were all with, almost all of them had at least 3 compartment problems, low albumin, and thoracic duct outlet. Most of them went to the left side. All of them, we confirmed patency. That's extremely important. Without patency, again, as I said, you should not do these procedures. And as far as what happened to them, oxygen saturation drops a little bit, but it's not too bad. Okay, so they lose a few points, but they're already used to that, so that's not bad. And the stent is a fixed diameter, so unlike the surgical procedure, which sometimes can allow just for expansion and then more they get bluer, stent is fixed, so they're not going to get bluer with time with this most likely. The pressures you can see in the innominate vein down significantly. Atrial pressure doesn't really change that much, and a mean pressure in the innominate vein. What is this? Oh, mean pressure difference, right? Goes from 11 to 1, and their symptoms get better. So these procedures, as I said, work. But again, we know, for example, now that if your end diastolic pressure is too high, then this procedure is not going to work. And I think because we don't have too much time, we'll skip this. Okay, but in our patients where we did this, where we did a lymphatic procedure, many of them have stable albumin, almost no symptoms, no multi-compartment symptoms. So this was the worst of the worst. No multi-compartment symptoms, normal albumin, and doing perfectly fine with these kind of combinations. There were 2 of them that had partial resolutions and 4, and there were a few patients that had no resolution, and we know now why that is occurring. So if you have a thoracic duct obstruction, this is not going to work. You need to go to transplant. Nothing you're going to do is going to work. There's no PLE procedure, no decompression procedure you're going to do. There's nothing to do, and it's just not going to function. Important for these patients, as I said, is to have a thoracic duct. So no matter what you do, if you have a patient coming in with a multi-compartment problem that involves the chest also, you never, ever, ever, ever shut down the duct in these patients. Even if they have some symptoms in the chest, you can't completely embolize the plaster bronchitis or whatever. Go to a decompression, do multiple selective procedures, but if you shut down the ducts, they're done. You're done with them, and you will have to either get them to transplant or they're going to die from that. One more thing to look at this patient population is what we call this precision lymphology, right? So these patients, as I said, have a susceptibility. There is a phenotype, what is the symptoms and what does it look like? But there's also a genetic susceptibility to at least some of our population. And there are medical treatments for them, and those need to be considered. And it's those especially true for patients with Noonan's that you will be dealing with. Adults with Noonan's with heart disease and trisomies, you will be dealing with that. And this is where we discovered some of these drugs. This is one patient with not heart disease, but we discovered that he had I can show his face. He's all over our internet. We've done many stories about him, but he had a rhesopathy, just like the Noonan's patients. We did not know that. He presented with just a pericardial effusion. It looked like a normal kid. We did 7 procedures on him, including 4 surgeries, and just made the kid worse, send him home on palliative care because we said, listen, there's nothing we can do. Thankfully, we worked with Hakun Hakunarson, who's an amazing geneticist and scientist, and he discovered the gene, did a zebrafish model, was able to introduce this drug to the zebrafish, and we published about it in Nature Medicine. And when we gave the kid the drug, we got it approved somehow through the hospital quickly, and you can see that the kid's respiratory parameters improved dramatically very quickly. Kids' lymphatic system completely remodeled. So I didn't know that they can do that, but within a month, they lay out an entire new network, and edema resolves in this kid. So things get much better. Like literally, it's like a miracle drug, these drugs. And this kid actually is now going to college, and he waitlist. This is him in his sister's graduation. So things get much better. This is extremely, extremely important for some of our Noonan's patients, almost all of them probably, right? But this is a girl, and now she's an adult. But she presented with severe PLE and GI bleed because of a lymphatic abnormality. This was her hemoglobin level. She came to us with intractable bleeding. We were just infusing her all the time. This was her albumin level. We did do a procedure to stabilize her PLE and shut down some of the things and get the bleeding to stop. But ultimately it came back, and then we started her on the drug, and you can see that even the stuff that she had in the chest completely remodels and resolves, right? So she no longer has this abnormal perfusion in the chest after starting on the drug. She still has an abnormal central lymph system, but the channels in the chest that were able to flow retrograde have now developed new channels that probably have functional valves, so that doesn't occur. And all her symptoms of PLE and bleeding resolve, and this is the reason. This is her gut. Before, with lymphangiectasia, vascular ectasia, you can see boggy and all that kind of stuff, and within a month of starting the drug, everything is completely normal in her gut. And she, in addition to that, undergoes many other things. She undergoes puberty. A lot of the Noonan symptoms that she had before gone away. She now is in college. So really magical drug when it works for some of these patients, and more that we need to look for with our population, because again, we have many drugs that we use to treat cardiac problems. We really don't have any drugs except for this one that treats lymphatic conduction problems. And so this is something that, you know, we are actively thinking about. Vivica, our collaborator, is actively thinking about. I saw Grushin a little while ago on the call also. Grushin, a close friend of mine, and is always thinking about this kind of stuff also. So we need to develop this stuff together. So I'll just end because I know there's some questions. Just saying that T2 imaging is good for screening the thoracic stuff, and needs to be just done throughout life. We just need to look at it and see what's going on over there, because it will tell us what is ultimately the clinical symptom of our patients. Lymphatic is what we use for PLE and for screening for PLE. Multimodality imaging is needed for patients with a multi-compartment failure. And again, in those patients, you need multiple different kinds of interventions, but decompression is essential, and don't shut out the ducts in those kind of patients. But just in general, don't do thoracic duct ligations and embolizations if you can somehow avoid that. And I'll thank you all again for inviting me. I'm a lymphomaniac. If anybody wants to learn more, come spend some time with us, wants to call, talk about patients, we are always available. And again, thank you.
Thank you very much, Dr. Dori. It's been an excellent talk. So I have a million questions, but I'm going to start with the questions from the chat. So the first question in the chat is excellent presentation. Could we estimate the myocardial edema from T21 imaging to try to correlate increased lymphatic pressure on congestion to cardiac edema?
So the answer to that question is potentially, and we've actually, I spoke to my radiologist and we started looking, but anybody out there who wants to do that study, right? Because there's ways to do T1 mapping, but there's also ways to do T2 mapping. And we've done it in a few patients, and we've seen that the T2 signal is higher in the myocardium in patients who have lymphatic problems. We just didn't get to do it. So if anyone out there wants to do it, I think it's an excellent study. I think there's maybe some problems with it because the myocardium moves a lot, but I think if we do it carefully enough, I think definitely we will see increased signal in T2 signal in the myocardium that will ultimately correlate with the fibrosis and stiffness of these patients. But future will tell.
So Grushin has says that excellent talk, but also has a question that I was thinking about as well. So I do heart failure in ACHD, and I deal with a lot of Fontan patients that go through transplant assessment. And the thing that scares me the most is transplanting a Fontan patient with bad PLE, because of what the PLE does not resolve immediately after transplant. The Grushin's question is how we look at lymphatics after transplant. So do they change after? And there's some papers suggesting that the PLE takes almost a year to resolve after transplant. So do you have any data of what happened to the lymphatic system in these patients?
Yeah, so lymphatics, so yes. So yes, first of all, we have some of the data. I mean, we haven't published it, but maybe we should put it together and publish it. So what happens, because it is really related to the CVP problem, right? So the networks that cause PLE are not going to go away. They're going to be there. And we know that because we've had some patients who had a transplant who after the initial transplant period, when the CVP improved in the transplant patient, the PLE resolved, but then when they got rejections and all kinds of stuff like that, PLE returned. So we know that those networks and the susceptibility for it is going to stay. The reason why it takes a while, because when you transplant the patient, you connect the veins and you connect the arteries, but you don't connect the lymphatic. So transplanted hearts are stiff and they are edematous. And the CVP after transplant doesn't get better. It actually is worse initially. And then it takes a long time, slowly things get better. The question is, does the lymphatic system ultimately connect to the CVP and things get better? Can it find ways to decompress itself? But eventually, when the heart becomes less stiff and the CVP drops, then now you've lowered lymphatic production, right? You increase drainage, and now your PLE can resolve. But this is why it takes such a long time. But there are some patients who have big holes in the duodenum, and no matter what you're going to do, even if CVP drops to completely normal, it's not going to go away the PLE, and they're just going to need a PLE procedure. But at this point, you're doing a PLE procedure in somebody who has a two ventricle circulation, and their CVP is now hopefully normalized. And so when you shut down the holes, the PLE should, in principle, just go away. But
So,
yes, but the circuits are going to stay there. So at any point in time when the heart fails, PLE is going to come back most likely.
that goes to my next question. So
Yes.
this is a probably provocative question. Should we treating the in patients with severe PLE pre-transplant? Should we be doing a PLE assessment and treating these channels prior to transplant, or that would be too much? This is just a provocative question. So I have these patients that do go to transplant with severe PLE, and they are already, with a huge amount of losing a lot of albumin and low albumin. You are really scared what is going to be the outcome in the first in those months that takes for the PLE to resolve. And in these patients, would it be worth to do it before, or should we wait until the transplant happens, and if they don't improve, to do it afterwards?
Right. So I mean, it's not a provocative question. It's an excellent question. And again, so if you have severe PLE and severe multi-compartment problem, your transplant outcome is not going to be great. So those patients, their mortality rate is probably going to be higher than your regular transplant patients. Now, I know Kurt, and we've had a debate about this, right? He showed that if your selection criteria is correct, if you have just PLE and you take them into transplant when they're clinically doing well, then most of those will survive, and a lot of those within months, the PLE will resolve. So those, I think, it's easier to get through the transplant. Now, in our institution, for example, if you are a severe PLE with now starting to show up with ascites and stuff like that, there's no way you're getting a transplant over here. And actually, that's the case for many institutions now. It's very hard to find a place that will transplant somebody who has one of these multi-compartment PLE patients. So you have to treat them, absolutely. And we've done that now in multiple patients where we have treated them. There's actually a girl that we could not transplant her because she was multi-compartment, but we did a PLE procedure, stabilized the albumin level. We were careful in what we were doing, stabilized albumin level, and then immediately sent her to Stanford where they transplanted her, and she's doing wonderfully. So absolutely, yes, there are many cases where doing an intervention to just stabilize things will make them much better, and I think will make them a much better transplant candidate.
So there's a question here from Grushin that says you mentioned that reconnecting the thoracic duct when it's obstructed. Can you explain how do you do that?
Well, so first of all, I don't do that, but we have surgeons. So we have one of our cardiothoracic surgeons, Katsu Maeda, and one of our general surgeons, Pablo Laje. They are also now experts in microsurgery. So there's techniques, and the one who taught Pablo is a friend of mine, Guido from Belgium, who learned with the Italians. But there's microsurgical techniques that allow you to connect lymphatic ducts to veins. And so those are techniques that just need to learn. The tools are different, The needles are different. The threads that you use to do the surgeries are much smaller. It's like an 11. Like we usually use like a 2 or 3, whatever, for doing the suturing, and this is an 11 wire, so it's like a hair. So you need a microscope to see these things, but it's a surgical technique.
So I'm we're about to time, but I'm gonna end with probably the one. No, I'm not sure if the $1 million question, but the question that I always have in my mind. So, at what point we should be considering to offer an intervention for treating PLE in adult patients? So we have these patients that we throw at them steroids, midodrine, PDFI inhibitors, octreotide, heparin, but of course, not all of us have the possibility of having access to someone like you that is very expert in doing that. But in your center, at what point you would consider to offer someone a procedure for treating the PLE?
Oh. So, and I know this is always the problem, right? So you're going to throw all this stuff at them, and it's not going. Most of those things that you're saying are not going to do anything, right? We are just throwing it. We are just throwing it because we are just desperate, right? So people are latching on to different things. Like this week, somebody said something, one paper about midodrine, and then everybody just started trying it, and then some people say it does something. But I have plenty of patients and people that have told me that midodrine doesn't do anything. We know steroids work. So, but in steroids don't work at all in an adult. If an adult presenting with PLE, it's too late. That's it. Steroids are not going to do anything. So we don't even put adults on steroids anymore. So the pathway for these patients now, sitting and looking at them is not going to do anything. They're going to decline and deteriorate. No reason to do that. Steroids, try, doesn't work. Take them off of it. The side effects are horrendous. Okay. So the pathway is, if the initial presentation, usually not an adult, but an adult also, give them the diuretic, cardiac cath them, make sure everything is optimized. Give them the diuretics, the aldactone, high dose aldactone, maybe it does something, maybe it doesn't. Put them on sildenafil. We do that sometimes. And if those things get the PLE under control, then that's fine. Just watch them. If not, then you move on to the steroids. No reason to just keep on watching the kettle. It will boil at the end. It's not going to get better. Give them the steroids. Try it for 3 to 6 months maximum. Get them to a dose of 9. If it's not doing anything, wean them off. It's not going to do anything, and it will cause problems. So get them off of there. If you've done those 2, you want to try octreotide, heparin, and all that kind of stuff, go ahead, throw it at them. But if you're not seeing that any of these things are doing anything, then that's it. Then we have a pathway. Then they need to go for a lymphatic evaluation, a lymphatic procedure. If they're just PLE, then maybe just a PLE procedure. We'll give them a few years, and then we will bring them back if they need, and we'll do a PLE and a decompression. If they are already multi-compartment, then they're going to get a PLE intervention and a procedure. That will give them who knows how many years. Again, as I said, 3-4 years, we're out, maybe 10 years, maybe 15 years. And then when they fail that, they're going to need to get to a transplant. So that's the pathway that they need to take. Sitting and just keep on throwing at them and just hoping that things are going to get better is just not going to happen. I've never seen it. You've never seen it. And you're much more experienced than I am, right? They just keep on getting worse. So that's the pathway. There's no reason to sit on them. The healthier they are when they're going to get the transplant or get the lymphatic procedures, the easier it is going to be for us to treat them.
That's a great approach. And on that note, thank you very much. I think we are just above the time, but it's been an excellent talk, and really, really encouraging for these patients. And to all of you that have joined us, thank you for joining us. And good morning, good afternoon, or good evening, wherever you are in the world. Thank you very much, Dr. Dori. Bye-bye.
Thank you, everybody. Bye-bye.
Thank you. Bye.